Deal. Record is on. So, hey, Bob.
Well, good afternoon. Good to see you again.
Yeah. How was your morning?
We had a great session yesterday, I have to say. We didn't get a chance to talk much about it right afterwards because we were running a little late, as always. But you had a great turnout, and I got to tell you, we had a lot of great questions that they asked yesterday.
Absolutely. Which, for those who are watching, that's the purpose of this video, is to continue the session we had, and we're going to review the session we had with our Power for Parkinson's peeps. So as you all know, Bob is the famous pharmacist, Bob the farmer, we call him. But not only is he full of knowledge, he is definitely generous with his knowledge and very kind. And I did notice yesterday, you stayed after and talked with people for a long time, which was so kind and so cool of you. So thank you.
There were so many questions. We just couldn't fit it all in,
Yeah.
It's a shame.
Yeah. Well, we'll have more, and then future sessions. Yes. And of course, you're really involved. So therefore, there's no lack of time to, in the future. But for today, one thing too, and I want to apologize to everybody else listening. If you hear my dogs chewing a bone, I gave him a treat to be quiet. But can you hear it, Bob? Can you hear him chewing?
I do not know.
Oh, good. So I'm probably a little bit more sensitive to it than there it is. I'll mute when you're talking though, and then unmute when I talk, just in case they get a little bit louder. They don't get treats very often. So when they do, they just love them. Well, they're not, they're spoiled, but
yes, I know all about that. Yes,
you would. So let's do this. There is a few questions I have written down from yesterday, and I actually wrote down some afterwards that were discussed yesterday at our session that would be really important to revisit for those who couldn't make it and for other people who are watching, because this is going to go out to even other people who are not in our particular program, but maybe in other programs. But so let's just jump right into it. One of the things I think is really, really important for you to just spend a couple of minutes on would be, it's kind of twofold, and maybe threefold actually. Digestion, and the whole, the medication in the gut and the intestine, and all that whole science of the digestion and where the medication needs to get. And then with that, it came up yesterday about when do we eat our protein, and potential digestion issues like constipation and difficulty with digestion. So just in a few moments, not a few moments, let's take as long as you need, but let's cover digestion. Okay, first.
Sure.
Okay.
Yeah, absolutely. And this did come up in different forms yesterday, because it's of tremendous concern for almost everyone with Parkinson's. There's multiple digestive issues, and part of the problem, we're dealing with the stomach and we're dealing with the intestinal tract. The stomach, both are under siege because they're under the control of the autonomic nervous system, and that circuitry in Parkinson's is not working effectively anymore. It's either not working or misfiring, or it's slow. For most cases, like everything in Parkinson's, it's slow. The impulses and the nerves, the messages are not getting there promptly enough, let's say. So we'll start with the stomach. And in that case, most patients develop over time what we call gastroparesis, or delayed gastric emptying. It's just a slow movement of the gut. That peristaltic activity that we normally see in a healthy stomach, when we digest or put food in, it gets digested, it gets moved along the tract into the next section, which would be the small intestine. Unfortunately, in Parkinson's, that process is slowed. The peristaltic movement is slow. The stomach, the digestive process is slow. So things get hung up and stay in the stomach too long. And one of those things is their levodopa. And that's part of the problem dealing with levodopa when we use it orally. It gets hung up in the stomach. It does not want to be there. Unlike their other medicine that they take for their Parkinson's, they're perfectly fine being in the stomach. But levodopa does not want to be there. It needs to get moved along to the next section, which is the small intestine. And that's where it gets absorbed most efficiently. So if it's sitting in your stomach for an extra 45 minutes or an hour, that's an extra 45 minutes to an hour. You're not going to get switched into your on position and have those baseline symptoms get alleviated. They're just hung up. And that's one problem. The second problem is, even if we get it out of the stomach and we get it into the small intestine, it has other issues. First and foremost is there are food-drug interactions that can happen. One of the biggest ones that we talk about a lot is protein. Protein has the ability to compete with your levodopa to be absorbed. The absorption sites along the small intestine are very selective. And what happens is protein, just like levodopa, gets absorbed at the same exact sites together. So the first one that gets there is the one that's going to get absorbed first. And it takes time. Even when it gets absorbed, we have to get it from the small intestine to the brain to do what it needs to do. That's time consuming. So if the protein manages to show up first, then the levodopa's got to sit and wait for the protein to do its thing. So it's kind of a simple, basic explanation, but it drives the point home about taking the two simultaneously. So if you need to take food when it's time to dose yourself with your levodopa, carbidopa, try to not take it around a protein meal, perhaps a carbohydrate meal, a little a toast or crackers or something like that, more on the carb than on the protein. That won't interfere with the absorption of it. The other issue you have is constipation. This is a huge issue amongst the Parkinson's community at every level. Some are severe, some are mild, and anything in between. And that's also a problem, because as the constipation begins to continue, you get completely backed up. And we need to move that waste material along, because if the waste material is there for too long, that in and of itself causes problems. And it also blocks the absorption sites for that levodopa. And patients will find on those days when they're really or have been constipated, they're going to get less response from their levodopa than on those days when perhaps they've had a relatively decent bowel movement, or in some cases, patients cycle from constipation to diarrhea, then back to constipation and diarrhea. It's a vicious cycle back and forth. But even on those days when they do have some diarrhea, perhaps those are the days that they've been able to clean out the lower bowel. And then you take your levodopa, you'll find on those days, if you take notice, those are pretty good days for you because your levodopa is being absorbed much more efficiently because you're kind of cleaned out. It's a tough balance between constipation and diarrhea. And it's a battle. It's an uphill battle on a daily basis. But it all stems from the fact that that autonomic nervous system that controls those bowels don't work properly. There's also one final note, and that's a reflex that exists. It's called the gastrocolic reflex, and it's a means of communicating between the stomach and the intestinal tract. Essentially, what happens is when you take food in, the reflex kicks in, and what it does is the stomach will communicate with the large intestine and say, hey, this guy just had a huge meal. I need for you to initiate a bowel movement so I can finish digesting the stomach, and then I'm going to pass it on to you. That's the gastrocolic reflex. And under normal circumstances, that's exactly what happens. You eat a meal, a reflex begins, it starts a bowel movement to clear out the old food and allow for new food. But in Parkinson's, that reflex doesn't exist anymore. Or if it does exist, it's not working properly or too slowly. And the colon's not getting the message that there's more stuff coming down. You better clear it out. It doesn't get the message. It's misinformed or not informed at all about what's going on above it. So these are all intestinal issues that can happen. So that's why we try newer things coming down the pike for Parkinson's are going to try to be non-oral. They're going to be injectable things, maybe inhalers or patches to wear, because we can't keep dealing with this same intestinal problem. It's never going to get solved that way.
That's funny because I actually wrote a note said, hey, what about non-oral? Like, what are the options? Because I'm sure that would be the first thing that comes to anyone's mind when you said oral. So you could read my mind
Yes.
and you address that. That's good.
And to that point, there are several actually. There are some ones that are over in Dubai and in the United Kingdom. They have developed something very similar to what the diabetics wear, which is an insulin pump.
Yeah.
They have the same type of thing for levodopa carbidopa in a pump that looks just like an insulin pump. And it's a little subcutaneous needle that they put right, they wear the pump on their waistband or on their belt. And it's got a little tiny tube and a little small 29 gauge needle that the patient can just inject right into their abdomen, cover it with a little Band-Aid to hold it in place. And over a 24-hour period, it will infuse a liquid form of levodopa carbidopa subcutaneously, thereby avoiding all of the oral issues that we constantly see. The upside to that is, of course, now we're able to get a nice steady state level of levodopa rather than that sawtooth pulse pattern that we typically do see when you're popping a pill every 2 hours, 3 hours, 4 hours, because there's always fluctuations. And those fluctuations are what leads to dyskinesia or off time. So we can minimize that by doing things non-orally, and that's coming down the pike.
Very cool. And one thing I'd like to interject, and you'd mentioned part of it yesterday, and this is where you and I come together in making such a good team in the whole digestion issue. So you've got medication covered, and you'd mentioned yesterday one important thing, and I'm going to mention the other important thing. And I saw lots of wives tap their husbands when you mentioned this one important thing, that water helps with that digestion. And I could just see the women looking at their husbands saying, I told you, right? So
Yes.
Drinking loads and loads of water, and something we've covered in the past, exercise, especially getting strong in the abdominal area. So working on making sure your core is strong helps with digestion. So no, there are, and we'll wrap the digestion thing up, but there are some medications that do help with constipation. You brought it up yesterday, right?
Yes. So, there are typically they're going to start off your neurologist. Once you start complaining about it to your neurologist, they'll start with the basics. We'll start with dietary changes, increasing your fiber, obviously water. It seems like you just can't consume enough of it, but you've got to try to push to get those 6 to 8 glasses of water. And by a glass, we're talking about 8 ounces at each time, 6 to 8 ounce glasses of water every day. That's going to help on many levels, not just on the digestive aid. It's going to help regulate your blood pressure as well. It's going to help regulate your thermoregulatory system. Patients with Parkinson's temperatures are all over the chart. They have hot, cold, all over the place. Water cures a lot of that stuff. So that's super important. As far as more medication, things like Miralax is very commonly used for Parkinson's patients. It's very effective. It's non-habit forming. It's a great laxative to use. And what's nice about that is it's a powder and you can adjust it. So in other words, ideally, once you get yourself cleared out, you don't necessarily have to keep taking the full dose. Maybe you only need a half of a capful every single day, rather than taking the full dose, and just keep yourself regular that way. Everyone's going to be a little bit different. Everyone's got a different story as far as how they were able to manage that. But Miralax is very popular. Stool softeners are very popular too. They're important. This is another problem because water is very important in the body. And if stool lays around in the intestinal tract for too long, what happens is the body will reabsorb the water right out of the stool, and now it becomes hard. And once it's hard, it's very difficult to pass and move along, and painful as well. So that softener, in addition to a mild laxative, also helps pull back some of the water. That's what stool softeners do. They attract water into the intestinal tract. But if you don't have enough water in your body, there's nothing to attract there. So you really do need that fluid. It's very, very important. And then finally, if that's still not working, and there are other things, milk of magnesia and whatever it takes to get you going, but your doctor there are prescription medications, Amitiza and Linzess are a couple that the doctors sometimes can use to help speed up mobility and get things moving down there. Prucalopride is another one that I've seen used every now and then. But these are things that those are last resort things that we really don't want to see used if we can go to other choices. But the Miralax is very popular and very successful.
Yeah. Yeah. Who is that there?
This is Zeus.
Hey, Zeus. Hey, you. Oh.
So, all right, go.
We don't want to see him. We're going to probably have a couple of videos here because there's a few things that I really think that are important, and I don't want you to skip out on any details. But the one thing too, and it actually came up today when I was meeting with some clients at the gym. Now, the clients I were meeting today were not people with Parkinson's. However, we talked about sleep, and one of the ladies I met with today actually uses Benadryl on a regular basis to help her sleep. Now, you said something because a comment came up yesterday about sleeplessness, and we know that many people with Parkinson's struggle with sleep. So if you could visit the conversation, and especially the warning you gave yesterday about the Tylenol PM and the Benadryl. So I'm going to let you run with that, okay?
Yeah, and that's true. I mean, Benadryl has been around for years and years and years. It's an old school antihistamine that's been used for a whole host of things. It keeps refining itself, it seems. It started off as just a regular antihistamine that you would see in a cough and cold product. Then we use it really to fight allergic reactions. And it's been very successful. It's still used today in the hospital in an injectable form or an oral form. It can be life-saving for some patients that are experiencing allergic reactions. However, as an antihistamine, it belongs to a class of drugs called anticholinergics, and these have side effects. Even though it's an over-the-counter, and they sneak it in all kinds of products. We have products like Z-Quil and NyQuil and anything with PM after it, like Tylenol PM, Advil PM, usually contains diphenhydramine, which is the chemical name for Benadryl, which is fine for a lot of people, but not really for Parkinson's patients and not really for patients that are older. And by that older, I define probably somewhere 65 plus, maybe 70, the max, because there are age-related problems that are associated with that as well. So, for instance, number one, if you're a male, it can really aggravate urinary issues, particularly prostate issues. It can really aggravate the prostate, make it very difficult to pass urine for you. It's dry eyes and dry mouth. This is another side effect that happens with them. And there are already issues in Parkinson's. Dry eye and dry mouth is very common, not only from the Parkinson's itself, but also from some of the medication that they're taking for Parkinson's. Also hallucinations. This is another big issue. If you are prone to that or you have been experiencing hallucinations, anticholinergic drugs can worsen those symptoms or bring them back out again. And there's also that morning grogginess. It's not designed as a sleeping pill. It never was designed as a sleeping pill. So patients can take it, and now you wake up, you start your day foggy and what we call like a hangover feeling. Mm-hmm. And PD patients have a rough enough time in the morning getting started. Very often they're starting already off because they haven't dosed themselves all night. They've been sleeping, hopefully. So they have a rough time in the morning. So now you add that drowsy hangover effect from the Benadryl to that, and it can really beat you up in the morning. So It's really a drug they should be avoiding. If they need an antihistamine for its true use, which is to dry up excess mucus and secretions and coughing when you have a cold, there are other choices that they could use, and they should speak to the neurologist. It's just that particular one is probably not a good choice for them.
Interesting, and really insightful. I think that's awesome. Now, what would you recommend as an assistance for sleep with somebody with Parkinson's?
I'm sorry, what was that?
What would you recommend as something that could assist somebody to sleep better, or maybe try to get some sleep after restless nights?
Yeah. Okay. So, as far as an over-the-counter product, typically melatonin is one of the first go-to products that patients use. It's not harmful to them. It's very safe to take. Uh, Dose-wise, that's going to be very individualized. No,
Mm-hmm.
no two people are going to find success on the same dose probably because their levels of sleep are varied. But nonetheless, it is one of the go-to ones and one of the better ones out there. Again, I would avoid any of these products like Z-Quil or any kind of PM product because they're going to sneak into Benadryl for you.
Yeah.
Now, the other choice, there is a prescription item called Klonopin or clonazepam. This is another drug that I've seen used quite frequently for patients in Parkinson's who have sleep difficulty. It's technically not a sleeping pill. It's really more of an anti-anxiety agent. It belongs to the group of drugs called benzodiazepams, similar to like a Xanax or alprazolam, diazepam. But clonazepam is one that you see frequently used for a whole host of reasons in Parkinson's. But I do see it helping with, a matter of fact, I spoke to someone that was there yesterday that was actually using clonazepam for his sleep and doing quite well with that. So if they really haven't had much luck with the melatonin, the next step would be to bring it to the doctor's attention and they can prescribe. It is a prescription item, of course, but
Yeah.
that might give them some relief anyway.
Neat. Now, this is going to segue into another topic because when you were saying about melatonin, it led me to think about we have this newer store at the Square that is big into CBD, and that was brought up yesterday as well. And I actually have friends who use, Delta 8 to help them sleep. So in the category of CBD, when it comes to either sleep, when it comes to pain, tremor, medical marijuana, you had a little, that was brought up again yesterday. And just in your knowledge, I'm going to just let you run with that conversation.
Sure. So, and that's becoming more and more popular, obviously, as states are beginning to change their laws and rules and regulations regarding it. We're going to be seeing a lot more of it. And again, this is kind of super new on the front line. So there really isn't a lot of good clinical data here. But I know it's out there and I know people are using it. And honestly, from what the feedback that I'm seeing or reading or learning about is fairly positive for, I'd say mostly for a lot of people use it for anxiety. Now, anxiety is definitely one of the non-motor symptoms that we see with Parkinson's. Pain, which goes along, and often, unfortunately, pain isn't spoken about enough, but there is a great deal of pain associated with Parkinson's. So patients usually use them for those two reasons. Help them relax. Stress is always, and when they get nervous and stressed, their motor symptoms begin to worsen. The tremor gets worse. They become stiffer and nervous, and it's very difficult for them. And this helps them relax. And it seems to be some of the pitfalls here are going to be. We have to be very cautious about there are pre-existing conditions such as hallucinations. Are they predisposed to hallucinations? Let's face it, this drug, no matter how pure they say it is, it can have a hallucinogenic effect to it. Now, of course, they separate the THC out of this, so they say that's, but again, a lot of that has to do with how the product is prepared, and we don't really have a lot of uniformity out there from one brand to the next. You may get a batch this time that did wonders for you, and the next batch that you get may not be so good. So we haven't quite refined that process right now. But is it something that can be advocated? I think if it's wherever you are, if it's legal and you can obtain it, it's worth a shot. Of course, speaking with your neurologist first. But some of the anecdotal information that I'm getting back is it does seem to help them relax. It does seem to help with the anxiety. but we need to sometimes be able to differentiate anxiety from depression, and depression leading to either paranoia or delusions or hallucinations. Those can be some of the nastier side effects that we see with the CBD products. So caution in that, but right now it's an open field, and everyone is monitoring it right now, but no real good clinical data is coming back yet, but it's being worked on.
Yeah. Yeah, I like that you're even open to like studying the subject and kind of learning more and more. And something I just recently read was that even no two people respond the same. Like we got susceptibilities even when you're not dealing with Parkinson's. So if you and I try something, some CBD, something, it's going to affect us differently. So I guess it's one of those ones where people just have to really be cautious and
they really do.
Getting to their neurologist about what's happening.
Exactly. And like I say, just from one product to the next product there's going to be variance. It's not like when you take your prescription medicine, you're going to get the same 25 milligrams every single time you take it. We're not at that level yet with CBD products that,
Yeah, I'm sure it'll get there. Now you brought up hallucinations, and a good point was made yesterday in regards to a couple of things. And so if you would bring up, hallucinations, you mentioned yesterday that, and I stopped you just to get people to, hey, this is when you bring it up to your doctor. Because I do feel like people wait, just like you've said in the past, they wait to talk to their doctor about carbidopa, levodopa until they're really affected by their motor skills, when probably before would have been better. And when it comes to hallucinations, sometimes someone might just see like a shadow that may or may not in their head. They're like, maybe I really didn't see that shadow. But at that, you had mentioned at that point to bring it up. So I'm going to let you carry on with that. And if after you talk about bringing up when you may or may not see a shadow or something, can you talk about sundown syndrome? I mean, because I don't know if that's connected. Like if people get more of the hallucinations later in the day when they're tired. And more of my clients, and it wasn't brought up yesterday, but I feel like it needs to be talked about sooner than later. And that is the sundown syndrome effect with people with Parkinson's, where it does seem like later in the day when the hallucinations are much worse and the erratic behavior is much worse. So take it away.
Yeah. So, well, starting off with the hallucinations, we touched on it very briefly yesterday, and it's a great topic. Because it really does affect a lot of people. At some point, around 50% of Parkinson's patients will exhibit some kind of a hallucination, either because of the Parkinson's itself or every medication that you can take. If it's a dopaminergic agent for Parkinson's, it has a possibility of producing hallucinations as a medication side effect. First and foremost, patients need to understand it's not them. They're not going crazy. This is a side effect from the medication or an effect from the Parkinson's. But to your point about not being reported promptly enough, this happens all the time because it doesn't exactly, we don't start seeing little green monsters right away, or maybe not at all. It's a very gradual process. And like you brought out, very often it starts off if it's a visual hallucination. Now, hallucinations, there are 5 flavors to them. There are auditory, there is visual, there's olfactory, there's taste, and there's tactile. Those are all forms of hallucinations. Most commonly in Parkinson's, you're going to see visual hallucinations. And they always seem to start off later in the evening, around dusk, and when the brain is tired. It's exhausted from the whole day. It's been fighting all kinds of issues with Parkinson's. So it's susceptible to trickery. And our brain loves to do that to us. So in the early forms of the visual hallucinations, patients will often see in their periphery, very often to the distance, something flash by. Maybe if they even can catch a glimpse of it, it's usually described as something furry or small, like a cat, or a very small child. It doesn't always have to be, but that's usually what they see at first. And then a lot of times they'll move their head very quickly to see, no matter how fast they go, they never catch it. It darts in and out. But those are the earliest signs. Those are called passage or passage hallucinations. That's an indication. If the patient doesn't bring it up at the next appointment, the caregiver should. Because usually what will happen is the patient will turn to his or her wife or whatever and say, honey, did you see that? And they'll be like, see what? There's nothing there. There's nothing. Are you sure you didn't see that? You know, that's how that goes. But if that's starting to happen, if that kind of an exchange is going on, that needs to be addressed. Because what happens is very often those hallucinations begin to converge. They start in the periphery, but they become more centralized. And as they become more centralized visually, there's much more clarity to them. So now patients are not just seeing a shadow, now they're beginning to see forms and shapes until the point that it develops where they actually see a person or a child. Very often it's usually very small people or very small furry animals. Cats are very common in their early hallucination form, but that can grow and they don't always stay. Sometimes they're very benign. And as I mentioned yesterday, sometimes the doctor will choose not to even treat it. If it's infrequent and it's very benign, he'll just leave it alone, but he'll note it in the chart. Because, and that's the whole key. By reporting it to them, even if they choose not to treat it, it's at some point down the road, you may need an additional medication added to your regimen beside your carbidopa levodopa. And the selection process is going to depend on whether or not, he's going to see, gee, 6 months ago you were complaining about hallucination. That's going to eliminate some of his choices that he can put you on, because he'll just precipitate or worsen those hallucinations. So it's always good to make sure you speak to your neurologist and let them know, and let him decide what's a good hallucination and what's not a good one. Because they don't always stay good. I have to tell you, a lot of times they do. You know, I had a woman one time, I was watching an interview with her. Her daughter was saying, I felt bad. My mom sees angels all the time. You know, what a wonderful hallucination that must be. Well, today they're angels, but tomorrow they could be demons or nasty angels or whatever. And you never know how that's going to happen. So it's always good to make sure you bring that to light whenever you're at the neurologist, because it does make a difference.
Now, Bob, we're going to have to wrap up this session, and then we'll talk we'll get back on. I have my list here, and so when we get to the next session, let's keep that conversation going a little bit about hallucinations. And then move on to like sundown syndrome and just some other things, because you said something way in the past, not only hallucinations, but there's delusions that are separate. You know, there's categories of things that sometimes we don't note. And I hope caregivers and spouses are watching this, because truly you nailed it on the head when you're at a neurologist appointment, that even if your spouse sees something that's just out of the ordinary, they should bring it up. Because I've been with clients before who are like, hey, did you see that person pass by? You know, and they think it's real. And, you know, it's us to, you know, recognize that, you know, and I, as a trainer, I mean, I'm not going to make a big deal of it. I'll be like, you know, there's people going by like crazy around here. It's busy at the gym, you know. But I'll look at the husband and he'll know what just happened. And that's the time to go ahead and bring that up, you know. So it's important to advocate for your spouses.
It is. And one other closing note on the hallucinations, in those early days when they're just seeing these peripheral things, a lot of times the patient may not even say anything, and they'll chalk it up to, it's my cataracts are acting up, or it's my glaucoma, or it's my macular degeneration. It can't, they're not even thinking about it, a hallucination. They're blaming it on many other eye problems, which are very common with Parkinson's as well, I might add. So it could go months or even years before that hallucination issue is even brought up in conversation, because they're thinking it has something else to do. The same thing with the auditory. You know, they'll turn to their spouse, say, did you hear that? Did you call me, hon? Is that? And they're like, no, I didn't say anything. It's your hearing's going bad. You haven't been hit. Right. And they blow it off, and they don't realize what's really happening.
And so that gives permission with somebody with Parkinson's, because it's not a bad thing. It's a normal thing. So if you hear, or if you smell something that no one else smells, if you see something that no one smells, if you're feeling funny feels, just write it down and bring it up. That's no issue.
And let the doctor decide. You know, he hears this all day long. This is very, very common. You're not a freak. You're not abnormal because you're having this. This is a very common issue. And in most cases, when it's done early enough, it's very easy to resolve. Sometimes just simply lowering a dose of one of the medications is all it takes. But nonetheless, it needs to be addressed as soon as possible.
Yeah, I think that's important to finish on, and important to have noted. And I appreciate every time when we can send somebody with something practical, and you're full of that. And I really, I know that our Parkinson's community values that tons. So for now, until next time, Bob, thank you again for taking time out of your day to have a conversation with me.
As always, Tammy, always a pleasure.
Yeah, and there'll be many more.
All right, I'll see you soon.
Absolutely.
Take care.